Everyone. Hopefully you can hear me okay. Welcome to the 8th Data Palooza. My name is Phil Bourne. I'm the founding dean of the School of Data Science here at the University of Virginia. And it's a pleasure to welcome you here. For those of you in the other room, you already heard me say this, but on this wonderfully sunny day. It's sunny for data science, at least. So I really want to just begin by acknowledging our veterans and the service that they provided to us and our country. We're exceedingly grateful on this day, Veterans Day. There's a day of caring table outside, and I encourage you to fill in a card for our veterans and provide your best wishes and thank them for their service. So thank you very much. I'm going to keep my remarks very short because it's much more important we listen to the research. But I do want to just acknowledge our sponsors, LMI, Capital One, the Sports Analytics Club Program, the Nobel Research Foundation. Oh, sorry, no, I'm getting mixed up here. It's a research day. The Noble Reach Foundation and QIM. Program books, if you don't have them already, are available. There's a QR code around the place so you can get if you want the program online. And today we're going to hear, initially here in this room, data in health equity. And we have three speakers, Suretha Sharma, Rupa Valdez, and Paul Perrin. And we're very excited to have them. This is certainly an initiative. Health disparities is an important initiative in what we're doing in the school. It's something I was involved in at NIH before I came here, and it's very important to us. So thank you for being here, and let's let the good times roll. Thank you. I will let the speakers introduce themselves. So we have first up, Suretha.
Hi everyone, I'm Sucheta Sharma. So I'm an MSDS alum. I'm a graduate from 2020. Today I'm a data scientist here at STS. I work with Professor Brown and Johanna there, who is the iThrive Director of Informatics. So I'm excited to be here to present our work on health disparities among COVID-19 patients, looking at, with the help of medical record data provided by National COVID Cohort Collaborative. So this is the team here. We also have a lot of undergraduates, graduate students, and interns work with us on all these various projects, but this is mainly led by Professor Brown and Johanna Lumba. So the main objective of our project is to analyze electronic health record data, which is provided by National Cohort Collaborative to predict how patients, among COVID patients, their demographics and social determinants of health affect the medical outcome and the care or treatment they receive during their COVID pandemic time. So this is the brief statistics on N3C data. We have about 76 institutions contributing data to this site. We have about more than 16 million patients. We have their clinical information, their lab information, medical records, medication records, procedures, and their hospital visits. We have more than 20 million person-level information, like row-level information. We have about 6.4 COVID-positive patients. So this is one of its first in the kind in the country where we have access to such large medical record data, which helps us answering all these important questions. So where is all this data stored? So it's all present in N3C Data Enclave, which is a secured platform where the clinical data is harmonized, which is provided by these different contributing sites. The data can only be accessed on this secured platform which is approved and hosted by NCATS. So how is data collection and pre-processing take place? So we have the limited data set, which includes the zip level information for each patient, which later goes through this harmonization process, which is done by different teams. And then the data is structured using the OMOP common data model. So here are some of the projects that we have done in the past 2 years on health equity research. So this was done using the N3C data with iThrive in collaboration with different sponsors. So the one we did in 2020-2021 as a part of Data Science for Public Good was sponsored by Capital One and Deloitte. And the second project that we did was a part of the capstone for here MSDS students. And the last one was again done this year as a part of the Data Justice Academy, which is again sponsored by Deloitte and Oracle. So let's see what this first project was about. So here we were first interested in answering if there is any equity in patient care among the concurrent ischemic stroke and COVID-positive patients. So here we were interested in looking at only COVID-positive patients with inpatient admission for ischemic stroke, either 1 week before or 6 weeks after their index date. This was done in collaboration with Dr. Andrew Sutherland, who is a neurologist here at School of Medicine, UVA. The variables that we were interested in looking at included both equity and medical variables. In equity, we looked at race ethnicity groups, their insurance types. In the medical variables, we were interested in COVID treatments like ECMO and remdesivir, mortality, and their clinical comorbidities. Some of the conclusions we could draw from this work was, even though we saw non-Hispanic, they support the national population trend for COVID-positive diagnosis, we observed other trends for the minority race groups. Like Asian non-Hispanics, they had the highest mortality rate, and they were the highest receivers of ECMO, which indicates the severity among them. And yet they had the lowest average comorbidity number and receivers of remdesivir. The Black African American community have the highest comorbidities and the lowest mortality rate. Hispanic or Latino race received the highest remdesivir and had significant comorbidities for each patient. So the second project we did was to look if there is any kind of racial bias among the COVID-19 patients in care or treatment received based on their race ethnicity groups and their social determinants of health. So here, this was again a question proposed by Dr. Ebony Hilton, who is an anesthesiologist here at School of Medicine. She was interested to know if there is any kind of racial bias when someone comes into an ED and then if they're hospitalized based on the decisions made by medical staff at that time. So here, again, we looked at only COVID-positive patients. It was divided into 2 sub-cohorts. So we first looked at ED patients, and then we checked how many of them were later admitted from their ED visit. We also included the social determinants of health, further looked into special populations like patients with dementia, pregnancy, and housing instability. So some of the conclusions we could draw from this work was across all these 3 cohorts, the special cohorts that we saw, dementia, pregnancy, and housing instability, the Black African Americans consistently had lower odds of being hospitalized after their ED visit. We also saw that chronic lung disease and obesity were consistently, patients with both of these pre-existing conditions had higher odds of being hospitalized and receiving remdesivir. So when we were not considering the social determinants of health, race, the race feature, it plays a role for higher odds of being hospitalized and receiving remdesivir. But once we included the social determinants of health in our analysis, the race still played a higher odds in being hospitalization. Sorry, this moved. So being hospitalized, but it acted as a proxy for race ethnicity groups in care or treatment received. So basically, what we were interested with that project was to see if any of the minorities groups had any kind of racial bias, facing racial bias when they come for treatment or care. So with all the analysis, we saw that the minority groups, in comparison to the white non-Hispanic group, had higher odds of being hospitalized or care received because of the severity in their cases. So the next project we did with the MSDS students was we wanted to see if we can predict the development of heart failure post-acute COVID phase by race ethnicity. So this was again done in collaboration with Dr. Sula Muzimba, who's a cardiologist here at School of Medicine, UVA. We looked at different machine learning techniques, like tree-based techniques, logistic regression, to answer this question. So some of the results from this paper looks like this. So on the left, we see the combined race ethnicity graph, the ROC curve, where we have an AUC score of 0.75. So the list of features that was used to predict this were the patient demographics, the social determinants of health, the STOH features, the variants of COVID like pre-Delta, Delta, and Omicron, and some of the pre-existing and treatments received during their COVID phase. So on the right, we observe that age, the length of hospitalization, STOH features, and some of the kidney disease was also one of the main factors that, that predicts if a person can develop heart failure post their acute COVID phase. So we eliminated all the patients who have had heart failure before, and we only looked at the possibility of developing a heart failure post their acute COVID phase. So some of the limitations of this EHR data is, the study is incomplete because the data is incomplete. We have a lot of missingness. We don't have complete information for all of these patients. The study, it also does not include individuals who identify themselves with biracial or multiracial or ethnicities, and we also don't have information for patients who do not identify their race. The harmonized data comes from multiple institutions, so there is, of course, a site-level bias, which we try controlling using different statistical models like generalized equations. We also have STOH variables at county level and not zip level. So again, the results that come from them also indicates a region level of results and not patient level results. Yeah, I think that's it. Thank you.
I'm sit here while I talk to you, and I'll explain that in just a minute. So I'm Rupa Valdez. I'm an associate professor in both public health sciences and in the engineering systems and environment department. My work is at that intersection, and I also bring in a background in cultural anthropology to the work that I do. So today I'm speaking to you from that professional lens, but I'm also speaking to you as a disabled person, which is why I'm sitting right now, because of my mobility-related disabilities. And my talk is going to be a little bit different. What I'm hoping to do today is to introduce you to the disability community as a health disparity population and to speak to you about some of the work that I've done, particularly from someone who does work in the digital health space. And I realized I forgot my clicker. Okay, so I'm going to start by talking about the health disparities that are faced by the disability community. So some of these are related to both structural and attitudinal barriers in the healthcare system. So the statistic that I always like to show is that over 75% of disabled people talk about barriers that they face in accessing healthcare delivery. So that could be anything from not having accessible exam tables to 90% of clinics don't have bathrooms that are accessible to many disabled people. Attitudinal barriers is another, so this is another statistic I like to show just in terms of confidence in the ability to provide care for this community. And then, of course, the health disparities that are faced by this community are also a factor of social determinants of health, which we talked about in this earlier presentation, in terms of differential rates of incarceration, in terms of unemployment, in terms of socioeconomic status. So that can be thought of kind of as a legal imperative or an ethical imperative for thinking about the disability community as a health disparity population. This is complemented by what I often think about as a legal imperative in terms of the Rehabilitation Act, in terms of people with disabilities having equal opportunity, the ADA, which specifically calls out healthcare as a space where there should be equal access. And then lastly, in terms of, sorry, my screen keeps going in and out. In terms of also the Affordable Care Act, which highlights digital health technologies and basically care that's delivered through electronic means as another space in which people with disabilities should be given equal access and quality of care. And then as a designer, I like to think about this as simply good design, right? This idea that we try to make our products, the digital health technologies we create, is usable and useful for everyone. And then the disability rights community is the one which put forward this concept of universal design, which some of you may be familiar with. But the idea came first with the idea that design should be accessible for people with a wide range of disabilities, but that this also benefits everyone. So if you think about someone like me who has limited dexterity in their hands or maybe limited use of their upper extremities, something that's really usable for me will be used for someone, let's say, right, it's really cold and your fingers are stiff in that moment, or you're trying to juggle holding multiple things, right, that there's other situations in which an able-bodied person would benefit from those types of designs. Okay, so who are we talking about? So 1 in 4 Americans is disabled. This is a statistic that was pulled from the American Community Survey. And then globally, 1 in 5 people live with disabilities. So I like to talk about this as not a monolith, which can seem really obvious, but who are we talking about? We're talking about people with physical disabilities, people with sensory disabilities, cognitive disabilities, and mental health related disabilities. And then even often we think about disability from a perspective of diagnosis, kind of from a medical, and I'll talk a little bit more about that in a minute, but even someone with the same diagnosis in terms of functionally, capabilities and disabilities that may look different. So thinking about the wide range of how disability presents. And then think about disability in terms of an identity. So some people may identify as disabled and have the exact same diagnosis as someone who doesn't identify as disabled, right? So there's also an identity component to when we're thinking about disability. And then this point, I always like to highlight too that this conversation about health equity for the disability community is really closely tied to conversations about other communities. So people with disabilities are more likely to be racial and ethnic minorities. They're more likely to live in rural communities. They're more likely to be older adults. They're more likely to be veterans. So we're talking about a lot of other communities that we often focus on when we're thinking about promoting health equity. So we talked about this. The systems are not designed generally to accommodate disabled people, both in terms of in-person health care, and then as we think about an expanding ecosystem into digital health, certainly in that space as well. All right, so our technologies remain inaccessible. So one, that people with disabilities, like other health disparity populations, are less likely to have broadband access. They're less likely to own the hardware that's needed to access things like telehealth, to access things like mobile applications, which are designed to support healthcare and self-management, for example, in home and community spaces. There's a lack of compliance with existing standards. So the Web Content Accessibility Guidelines are considered at this point kind of best practice in terms of creating accessible technologies. It was encoded within the update of the Rehabilitation Act in 2017, and yet there's really a lack of compliance there. Some of that stems from this idea that the standards are not clear and comprehensive enough in terms of how they're defined. Some of it also just stems from lack of enforcement, right? So most of enforcement for anything related to accessibility in the ADA in the physical space or digital space is based on legal action in terms of an enforcement mechanism. I'm trying to look at the last bullets I have on here. And then this idea that existing efforts have not always focused on the full range of disability. So there's a lot focused on, particularly in terms of thinking about certain types of sensory disabilities, but maybe not the full range of disability as I was talking about earlier. All right, so for this last little bit of this talk, I want to present some kind of a model for thinking about what I would call co-design, so kind of a movement towards thinking about community-based participatory research, and how do we engage the communities that we're talking about when we're thinking about health equity and promoting this type of work. What would a model like this look like for the disability community? For this, this was a paper that I wrote with many co-authors, both in industry, with nonprofit organizations that I work with, and other members of the disability community. As kind of a 5-step conceptual framework for thinking about this. And we just came back from the American Medical Informatics Association, and this paper we were really honored. It was recognized in several different spaces just for advancing this conversation. So the first is this idea of just understanding a broad disability context. I'm talking about this in terms of the disability community, but certainly this applies to working with any marginalized or historically marginalized community. So understanding the reasons for kind of really hesitation to participate in research, to participate in these initiatives, a history of institutionalization, a history of eugenics, right? There's lots of reasons for mistrust in this community for engaging in research. There's lots of debates within the community, so back to this idea that it's not a monolith, things such as language. So do we say people with disabilities or do we say disabled people, right? There's not consensus on how we talk about that, even just kind of as a very simple example in terms of a range of ways of thinking about, right, how we speak. And then I just brought up 2 models. There's many models of disability. A medical model is one that is what most people are kind of familiar with if you're coming in from a healthcare lens, which is the idea that disability is something to be corrected, that it's a deficiency in the person, versus a social model of disability that says it's not the person, it's the way that the environment is constructed. So for me, if these stairs are accessible to me, I can do these shallow steps, these 5 steps. If there was a larger staircase, this would not be accessible for me, and so then my disability, right, is intersecting with the environment is what becomes the barrier. So partnering with the disability community is kind of a second step. So the disability rights movement has a slogan, "Nothing about us without us," which is really, right, that kind of theme here. So the idea of really developing strong relationships with community organizations, and I always talk about, if you're thinking about disability, most organizations, there are some disability, like cross-disability organizations, but many are by, right, specific type of disability. So it's really about building a coalition when possible to have the widest lens and perspective in the work that you're doing. And then, of course, working with organizations throughout the process. So back to the idea of when we even think about what our research question is, what the focus of the research is, engaging community members in that. And this is something I've learned over many years of doing work in health disparities, not just with the disability community, but the questions that we might come up with maybe on the priority of the community, right, 20th, 30th on the list, and not the things that are most pressing in terms of, right, the experience of health disparity. So intentionally engaging a diverse sample. So this gets to this idea, again, across people with a wide range of diagnoses, functional abilities, and disability identities, again, because of the many ways disability is conceptualized and experienced, right, by people who are living with disabilities. Use a wide variety of accessible recruitment materials. So we think about, often we have things like, right, we put flyers out into the world. If we're using social media, certainly I use social media as a recruitment tool, right, making sure there's alt text on those, trying to make sure if you can, there's an audio version, right, of whatever you're putting out into the community, right, that there's many different ways that people access information. Thinking about plain language, right, if you're working with people with cognitive disabilities, making sure that the materials are accessible to those individuals. And then, of course, capturing kind of a wide range of demographic backgrounds, certainly, right, the experiences of somebody who identifies as a racial ethnic minority and disabled, right, may be different than someone who isn't, and certainly, if we look at the literature in terms of health outcomes, we definitely see disparities there. So this idea of responsive and accommodating study procedures, I often think of this as a conversation that goes out throughout the life of a study. Because, right, people's needs may shift over time. Certainly someone like me, I consider myself to have what I would call a dynamic disability. So there's some days I'm in a wheelchair, there's some days I'm not. It depends on how my body is doing at the time. So I may have different accommodation needs at different points in time. So we want to make sure that as much as possible we compared with alternate ways of engaging with someone. So I've done a lot of work in the community, so sometimes it's, we're doing interviews and it's verbal. Sometimes it's easier for somebody to text back and forth, right, to answer questions. Sometimes it's easier for someone to bring, right, a personal care attendant or a caregiver with them to engage in the activity. So just thinking, really broadly about how that engagement happens. And then lastly, building foundations for future work. I think of this really as a model of collective action as much as possible. So consistently recognizing the community as a health disparity population, since it's often not recognized as stuff, even though there's a lot of literature to support it. Sometimes when we think about health equity, this is not a population that's considered. And that, I think all of us that work in kind of a digital space can have some role in advocating for better standards for the work that we do. And then I talk about monitoring differential and unintended consequences of technology. So telehealth, I do a lot of work in that space too. And if we think about telehealth moving forward, there are concerns from the disability community, for example, that as we move toward telehealth, if it's seen to be, a cost-saving measure, it could be used as a way for cost containment, particularly if you think about the accommodation needs that somebody with a disability might have coming into clinic, or the amount of effort it would take, right, to fix an in-person environment. And with that, I would say just for kind of, the initial presentation talked about electronic health record data. And one challenge that we have in doing work related to disability and health equity is we don't have great ways of extracting disability status from EHRs. And so we're doing some work right now with the UVA health system to actually get the American Community Survey questions into our electronic health record and into the clinical workflow, so those questions are there. But there's a lot of really interesting work happening in natural language processing, for example, to think about, right, how can we extract different dimensions of disability from the EHR? So I'll end with that. Thank you. And just, of course, acknowledgements and references.
Hi everyone, my name is Paul Perrin. I am a faculty member here at UVA in data science and psychology. And unlike the school data science only being 3 years old, I am only 3 months old in terms of being a faculty member at UVA. Before this I was at Virginia Commonwealth University, but I drank both the data science and blue and orange Kool-Aid, and here I am. So the title of my talk is an international study of the prevalence and structure of neurobehavioral symptoms in individuals with long COVID. So you may have heard of this term long COVID, or persistent post-COVID syndrome. So it's a set of symptoms that appear after the COVID infection and generally last for 4 weeks or longer, although some scholars designate it 8 weeks or longer. And it's more common in individuals with severe COVID-19 presentations, but it can also appear in folks who have had mild COVID infections. And so some of the common symptoms include things like fatigue, general bodily pain, headaches, breathing difficulties, anxiety, and depression. But there are also a number of neurobehavioral symptoms. So these are things like headaches, dizziness, loss of smell or loss of taste, prolonged loss of consciousness, sometimes comorbid issues like stroke, encephalopathy, meningitis, seizures, or demyelinating diseases. And there are generally 3 theories that have found some empirical support for how the virus and its sequelae attack the central nervous system. So the first is direct virus infection to the astrocytes. So these are these kind of star-like structures that exist throughout the brain and spinal cord. They regulate a number of things, including cerebral blood flow. Second is overreaction of the immune system, or what's sometimes termed cytokine storm. And then the third is blockage of blood flow in the brain causing hypoxia, or a lack of oxygen flowing to the brain. So generally the current literature is kind of lacking in long COVID studies, particularly those that have large sample sizes or those that are from diverse global regions, and in particular, studies that use validated, so psychometrically validated instruments of these symptom patterns. So the current study had 3 aims. So we wanted to compare the presence of somatic or bodily, cognitive, and emotional neurobehavioral symptoms in a large international sample of folks with a history of COVID-19 infection. And we asked them about their symptoms 3 times. So before you had COVID, during the active infection, and now. And then we examined a number of risk factors for increased long COVID neurobehavioral symptoms. And then finally, we applied social network analysis to investigate the patterns of somatic, cognitive, and emotional neurobehavioral symptoms in a subsample that was Spanish-speaking. That was our largest subsample. And so we wanted to understand and map out the basic structure of neurobehavioral symptoms in individuals with long COVID, and we wanted to compare them to a sample of individuals who were Spanish-speaking and had never had COVID. So we had a large group of international researchers, both around the United States and throughout, in particular, the European Union. So we collected data from 1,001 adults from 32 countries who had previously tested positive for COVID-19 through either a viral or antigen test. So 650 of these individuals were Spanish speakers. Many of them were from Latin America. And they averaged about 175 days since infection. Now, this part's important. We collected data in March to June of 2021. So this was very early in the COVID pandemic, and this is just when the vaccination was starting to roll out. So the vast majority of these individuals were unvaccinated, and this, as a result, was an earlier strain of COVID-19, or one of many earlier strains of COVID-19. And then we also had a sample of 443 COVID-negative Spanish speakers from 19 countries. We recruited these individuals through professional mailing lists, collaborators' contact networks. We used Facebook groups and advertisements. And we also had a COVID-19 patient database from one of the collaborating centers. In this case, it was Mount Sinai in New York. All of these individuals completed the neurobehavioral symptom inventory. So this is a 22-item self-report measure of different neurobehavioral symptoms. And we, again, asked them to fill out the survey with regard to before they had COVID-19, during the infection, and then now. Here are some of the results. So I'm going to show you just a couple really simple numbers. So the D that you see up there is Cohen's D. And so for reference, a Cohen's D of 0.2 is considered small, 0.5 is considered medium, and 0.8 is considered large. So in terms of the somatic symptoms, you do, of course, see a major jump from pre-COVID to during the active infection. And then you actually see some improvement from active infection to now, so a decrease of 0.6, or in other words, a medium-sized improvement. However, the thing that was concerning to us is that we saw almost a large-size remaining set of somatic symptoms, so Cohen's D of 0.76. And then out of all of the symptoms that we examined that were somatic in origin, the biggest remaining symptoms were sense of smell, numbness, and dizziness. In terms of affective symptoms, we see that same pattern. We see just under a medium-sized improvement from during COVID to now, but we see a large size effect of remaining affective symptoms. Biggest remaining symptoms were fatigue and sleep. Again, those are all Cohen's D's at the bottom as well. And then for me, the most concerning point was the cognitive symptoms. So we saw almost no improvement in cognitive symptoms from when the individuals had their COVID-19 infection to now. This is 176 days later on average. So we didn't even reach the threshold of a Cohen's D small size effect in improvement. Further, we see a large size increase in cognitive symptoms relative to before individuals had COVID. Biggest remaining symptoms were concentration and forgetfulness. We then constructed just a couple basic linear regression models to see if we could look at demographic and other social determinants of health in terms of their prediction of remaining symptoms. So you see 3 sets of columns. You see somatic, cognitive, and affective. Here we have standardized beta weights. So these are controlling for the effects of every other variable in the model, and then you have a p-value next to it. We see here that men were reporting lower somatic, cognitive, and affective symptoms. We see that individuals who had another chronic health condition besides COVID-19 were reporting higher levels of long COVID symptoms across all 3 domains. Individuals who had received oxygen therapy during their active infection were reporting lower cognitive symptoms currently. So we actually see a preventative effect of being given oxygen therapy during the time of COVID infection. As you might predict, the more severe the COVID infection, the more severe the long COVID symptoms for all three domains. And then interestingly, we did not see cross-sectionally a decrease in neurobehavioral long COVID symptoms as a function of time since infection. So we actually saw the opposite, that people were not only not improving cross-sectionally, but their symptoms were worse the further out they were from the time of infection. We decided to look by global region because we had a pretty nice large international sample. And so these are covariate adjusted means. So these are controlling for the effects of all social determinants of health and then sort of calculating what the projected means would be, everything else being equal across these different global regions. So individuals in Europe and Central Asia and North America were reporting the highest somatic long COVID symptoms. We see that same pattern for affective symptoms, so lowest symptoms in Latin America and the Caribbean, as well as sub-Saharan Africa. And then finally, the same pattern again for cognitive symptoms. So interestingly, we see Europe and Central Asia and North America as reporting the highest levels of long COVID symptoms. And so, that's sort of traditional scientific approaches, but I'm really interested in combining traditional kind of linear regression models with more modern data analytic techniques. So we decided to use social network analysis, and we applied this to 650 Spanish speakers with long COVID and 443 controls who did not. And social network analysis is really nice because it models a cluster of symptoms as a dynamic system. So for the computer wonks in the room, we used the estimate network function in the bootnet package of R, Epic-Glasso routine, to create a network of partial polychoric correlations. We used regularization and compared the two networks using a permutation test. So on the left, we have the network of long COVID symptoms. On the right, we have the network of symptoms in people who never had COVID. There are two main pieces I can point out. First is that you see the control network really is disjointed, and you kind of have these somatosensory symptoms or those yellow symptoms forming their own cluster. By contrast, the long COVID network really is an integrated set of symptoms. So what we're seeing is something that is true in nature. We've got an actual visual map of how all of these neurobehavioral COVID symptoms are interrelated. And then within these models, you can look overall to see how they differ, and you can also look at particular kind of bridges within the network, or in other words, connections among the symptoms. And as you might imagine, the thicker the lines, the stronger the connections among these symptoms. So the biggest difference that we found was between the organizational issue and head, or in other words, headache node. So there was a very small relationship between headaches and organizational problems over on the right in people who had never had COVID. But for those who did, we found an extremely strong bridge between those two symptoms. So you might say, well, is it that people are getting headaches and as a result cognitively it's difficult for them to focus and to be organized? That could be true. Or we could also be seeing literally organic brain damage that is creating that set of connections between those two problems. So you might say, well, gosh, this is really depressing. I mean, we're seeing really persistent neurobehavioral symptoms in individuals with long COVID. And I would say, well, that's true. But nonetheless, we need to kind of couch this with some limitations and also think about what implications this has for treatment. So there are some limitations. We use online snowball sampling. And so as a result, this is probably a non-representative sample in these different global regions. So absolutely something to consider. And we might also have recall bias operating that plays a role in comparing a person's current symptoms to those either during or before the active COVID infection. And then so in terms of implications, individuals with a history of COVID are reporting substantial continued symptoms across multiple neurobehavioral domains. But Through research like this, we can actually argue as scientists that long COVID is a coherent, identifiable pattern of neurobehavioral impairments. And through these models, we can look at things like symptom centrality, where we can see which symptoms are really the ones that are maintaining the network and are most important in connecting everything else. And then from a rehabilitation or interventional standpoint, those are the key symptoms that you want to target in terms of fracturing the entire network. So I do personally have a number of colleagues who are working in the rehabilitation space with individuals with long COVID. In particular, I have some colleagues at University of Alabama, Birmingham, who have great pilot data suggesting that cognitive rehabilitation works extremely well for individuals with long COVID neurobehavioral symptoms. So you can think of things like maybe brain training games, but being really targeted to the particular cognitive impairments that individuals with long COVID have. And so what I would argue is that rehab services, and particularly cognitive rehabilitation, are critical for individuals reporting elevated long COVID symptoms. And then I would further argue that we need evidence-based, proven interventions to really target those set of symptoms. So, all right, that's all. Thank you.
We have time for a few questions. I'd ask you to raise your hand, get the attention of our microphone runners, and wait to ask your question until you are properly mic'd. And I'd ask our speakers to come back to the podium to answer questions, if that's okay. Or to the panel. Questions? Do we have any questions? Got plenty of time.
Hi. So all of those were fantastic talks, and I'm so glad I got to listen to them. They were really, really quite good. And if I could have private conversations with all of you, I'd be really happy. But so I'm just going to ask one question, and it's for the first speaker. So you presented a number of studies, and your second, I think it was the second one, had to do with social determinants of health, and you identified race as a factor for hospitalization. So I think that's fascinating, and it's a really great first step to see that there are these associations, but then follow-up is why. Why is this happening, and what can we do about it? So do you have any ideas of mechanistic associations or why this could be happening?
Sorry, I didn't get the last part.
Do you have an idea for why race was a contributing factor for hospitalization? Like, is there something we can intervene in? Is there something we're learning about it that we can change in our medical system?
Oh, Johanna, do you want to say something?
Yeah, that's a really important question. So Dr. Ebony Hilton was the first clinician to begin work on this with us, and then Sula Mazimba as well has done disparity work. And one of the things we've implemented in other projects that we've done is adding kind of explicit decision-making tools to the medical record so that some of this unconscious bias, hopefully unconscious bias, is mediated by having an explicit decision. And along with that, we do training around this. We, share the results of the research and say there are these patterns. And so a combination of the education and then tools where they also are then aware that this is being tracked and looked at over time has effectively changed these disparities in past work. We have yet to roll some of this out because this was national database. So really what we hope more is that we could publish and then have those results inspire that kind of local work. Some of the cardio work that's going on, we're doing locally at UVA to do exactly that, to lead to change in practice.
Thank you. Thanks again for presenting. I had a question really for any of you, but I guess for the same speaker, mostly I had a similar project when I was working here several years ago, and found that if you didn't control for anything, it looked like there could be much bigger differences than like if you controlled for just diagnoses. Kind of like that explains like almost all the variance here, to the point where some of the factors of interest kind of fell away. I was curious, like, if you found other, like, I don't know, confounding variables while you were doing your research.
So that's like one of the limitations, right? We did not control for, we could only control for the ones we had information on. Like Johanna mentioned, there is a bias, an unconscious bias involved there, but we have tried to control them for their comorbidities, for their county level information, their demographics, and then try to bring the results out.
I can comment as well. So a typical health disparities analytic approach is first to figure out, so let's say we're looking at this in the context of race and ethnicity. The first step is to see, are there racial and ethnic differences in some outcome, whether that's prevalence of a health issue in a particular community, whether that's rehab outcomes after, for example, having a diagnosis of a chronic health issue or disability. So first you try to figure out whether these groups differ. So that's step one. Step two then is to put a number of covariates into the equation, usually social determinants of health, that you think are going to account for those differences. And then you see whether the differences still exist, even after accounting for everything that you possibly can. So here my colleagues found some evidence that these social determinants accounted for a lot of the variance in these outcomes, but nonetheless, there is still some left over. And one of the problems that I think we run into with data science approaches is we often use what's publicly available. So this can be information in health systems, electronic medical record systems. So these are things like, participants' age or education level or annual income. But after controlling for these things, in my experience, we still see a lot of health disparities that persist. So what I think is incredibly important is incorporating some of the types of variables that Dr. Valdez was talking about. So these are things like disability identity. These are other more nuanced variables that are actually malleable and can be targeted with health interventions. We can improve a person's disability identity. We can improve a person's racial or ethnic identity, help them make it healthier. We can improve perceived cultural competence of healthcare providers. So we really need, I think, to meld modern data analytic approaches with also some kind of more nuanced variables that really are going to help account for that additional variance wherein these health disparities still exist.
Can I just add to that, for anyone who's trying to do this work for the first time, I don't know if this is working. Anyone who's doing this work for the first time, so NIH has some different tools that you can use in terms of questions that you might ask. So the All of Us data set is really great. They publish all of the different questionnaires that they have that look at different social determinants of health and have questions. And then the Phoenix tool, where NIH is compiling, different social determinants of health questions. So even about focused on specific social determinants of health, they'll give different options for validated questionnaires. So that's another space you can go if you're creating your own data set.
Hi, I have a question for the first speaker. So the N3C data, what type of patient information is available in that? Are there medical records or?
Yes, they're medical records.
And so would these be like results from tests that they've had while they're hospitalized?
Yes, at the time of their hospitalization, their ED visits, all their results it's mostly probably from the billing codes also, but these are different concept codes, the medical codes that are later harmonized and stored in these data sets.
Okay, great. And for the last speaker, so it turns out that it looks like COVID can continue to infect adipose tissue, fat cells, after the nasal infections are done. And I'm wondering if you've looked at a correlation between like body mass or obesity and long-term COVID?
That's a great question. I have not. As you saw, one of the biggest predictors of long COVID neurobehavioral symptoms was whether somebody had a comorbid issue. So obesity is one of the ones that's considered in that. But also, the host of chronic health conditions in general do exacerbate a person's risk for long COVID symptoms.
Thanks.
Hi, I had a quick question for Dr. Valdez. So what I loved about your talk was the human component. So I was wondering if you could elaborate a little bit further, because I think you mentioned a little bit about intentional design. So across the life cycle of what AI/ML is all about, what are your perspectives on like what does that interface point look like, right? To take the functional, the expert sort of like human-centric piece of it, to influence algorithmic design, to influence interface to technology applications, those kinds of things. Could you elaborate on that touch point?
Yeah. I'm somehow having a hard time, like there's an echo, so do you mind asking that question without the mic for me?
Sure, yeah.
Sorry, thanks, I'm just having a lot of echoes.
I love your human component of what you're talking about. Can you elaborate on that interface point between the human-centric piece of it, the influence, into the AI/ML development lifecycle? So how does like your perspectives, how does community perspective, how does end-user perspective interface into intentional design components for what AI needs to do and how people interface with it?
Yeah, that's a great question. So I think, I'm talking a lot about the work I've done, which is creating mobile apps or that type of work where we're creating some type of digital technology. And so we're thinking about everything, right, from the kind of back end in terms of what functionality needs to be present to what does the user interface look like. Certainly in terms of thinking about algorithm development, I would say, right, there's also a component, and actually we have a proposal we're putting together that has this kind of focus on a different population, but the same idea of how do you get community members involved in that process. So back to my kind of point about involvement throughout the life cycle, early on, back to what are the questions that we're asking? And what are the problems we're trying to address through AI? So making sure those problems and the tools that we're trying to create are actually resonate with the community that we're trying to create them for. And then again, having check-ins throughout. So if your technology is creating, right, your algorithm is producing certain types of outcomes or certain types of recommendations, bringing those back to the community and asking them, what does this mean for you? How do you interpret this, right? Because as the people creating the algorithms, we might have certain perspectives of what we're trying to do. Is that really the end goal for the community themselves? So having that check and that involvement throughout the process is also, right, reasonable and I think really important when we're thinking about health disparity populations.
Thank you. I have two questions. First question for the third speaker. I saw your study use a survey about sample size is 1,000. So I'm thinking about, I come from a health insurance company. As you can expect, the data will be really much larger. Has UVA have any mechanism to work with the private sector, replicate the same study but use a large data size? That's a question. The second question is for the second speaker. I come from a private insurance again, when we design a lot of product for our customer, like for chronic disease control, like a digital solution, how we work with the disability community? How can we do that? Thank you.
So yeah, regarding your first question, I think our first speaker had some great examples of kind of how to work with archival data to look at COVID and its outcomes. You pointed out, well, okay, survey data. So there are limitations to every type of data. There are absolutely limitations to self-report data. One thing that we could have done instead is look at like neuropsychological performance across different domains. So that way it's not just a person self-reporting what their issues are. But yeah, UVA has some great inroads. I work both at UVA and then also within the Department of Veterans Affairs healthcare system. And so the VA has what's called VINCI, or the Veterans Integrated Computing Network. And so researchers who are within the firewall can get access to literally the entire medical record system and ask those types of questions. So I think that's a direction that we absolutely are trying to move in our work, is moving beyond just sort of surveys and then asking kind of population level questions within huge databases. But again, the problem with those big databases is you often do not have the nuanced variables in there that you really need in order to ask the questions of, what is an actionable target for health intervention. So again, there's kind of limitations to both sets, and I think we really need kind of a combined approach.
Thank you for that question. I really appreciate it. So I have a couple initial thoughts. So one is in terms of thinking about patient-reported outcomes. So, right, again, thinking about what matters for people who are disabled in terms of the outcomes that they're, that are of importance. And when we're assessing different options, right, for treatment, for example, making sure that those are being evaluated from a patient perspective. So I think that's one thing that's really important. And tied to that is this idea of quality of life. There's a lot of conversation in the disability community as it relates to quality of life as an outcome measure, because often quality of life is assessed not from the patient perspective or from the perspective of the disabled person, but from the perspective of someone else like a clinician or a healthcare provider. And there's lots of studies showing, right, consistently that clinicians rank quality of life of someone who is disabled much lower than the disabled individual themselves. So again, when we're looking at treatments and thinking about outcomes, who is doing that rating? And actually trying to move away from quality of life assessments, at least in the way that it's traditionally done.
Please join me one more time in thanking our speakers.